We'll proceed live. We are live now.
All right. Well, thank you everybody for joining. Good morning, good evening, good afternoon at different parts of the world. We've got a lot of audience for the annual Saudi Hematology Congress. This is our second last day, and I'm very honored and pleased to introduce the bone marrow transplant and CAR T session today, which is full of action and full of great speakers, which are going to be presenting mostly live presentations from United States, Italy, Saudi Arabia, and all around the world. It gives me great pleasure to introduce this session because this is true innovation in the world that's changed the world for bone marrow transplant, CAR T cells, gene therapy. Well, today's sessions are going to focus mainly on stem cell transplant, advances in blood cancers, and tomorrow we're going to focus a lot on CAR T cells. Today we have two sessions. The session one is going to be advances in blood cancers and BMT and CAR T therapy. Later on, we're going to hear a lot more about Gvhd in the second session, CAR Ts. We've got moderators for each of the session, and two of the moderators are currently present, and I will let them introduce the speakers, but it gives me great pleasure and honor to chair today's session. And without further ado delay, I would love to introduce Dr. Ahmed and Dr. Mohsen Zahrani as the moderators of this session, and they will go over they will introduce the speakers in detail. But it's one of the best conferences that you can see and hear around the world because not just participation, but because of the wealth of heterogeneity of speakers that we have globally. So on to you, Dr. Ahmed and Dr. Zahrani. Thank you very much. Please go ahead.
Thank you, Dr. Shahrukh Hashmi. And it's a great pleasure for me to be a moderator today for this session today. I'm Dr. Mohsen Al-Zahrani. I'm a hematologist and stem cell transplant physician at National Guard Hospital, Riyadh. And my co-chair is Dr. Ahmed Barifa. He's a consultant hematologist at King Abdulaziz University, Jeddah. We will moderate the first session, and we have three interesting topics with three eminent speakers. So I will give the microphone to my colleague, Dr. Ahmed Barifa, to introduce the first speaker.
Thank you, Dr. Mohsen. It's my great pleasure to introduce Dr. Aaron Goodman, who's a well-known hematologist, and he's specialized in malignant hematology, including lymphoma, leukemia, bone marrow transplant, and CAR T cells. He has a special interest in CAR T cell and also in rare disorders, including cutaneous lymphoma, which is one of the interesting fields in hematology, and also in rare disorders, including Cns Disease and other rare hematological disorders. He is a hematologist in the Department of Medicine in University of California, San Diego School of Medicine. He published many peer-reviewed articles and book chapters with excellent reputation scientifically, and also very well-known active hematologist on Twitter with very useful educational information through Twitter at the Papa Heme Twitter account. So without further ado, Dr. Aaron Goodman will present for us a lecture on advances in malignant hematology. So the mic is yours, Dr. Aaron Goodman.
Thank you for the introduction. Thanks for having me. It's a pleasure to be speaking to you guys. It's good morning here in San Diego. It's about 8 o'clock in the morning. And I think it's probably evening time for you guys. So this talk, it's kind of just a few it's kind of random things I put together that I think at least might change my practice. Some might be old to you guys, but I think these are important things that may potentially change my practice. Not too much CAR T stuff that I know is going to be in later talks. So we'll get going on the presentation. Let me just, so these are my disclosures. I always, if you do follow me on Twitter, I like starting kind of, let's wake up with some board questions, get our brains going, get us thinking. These are all cases from my clinic. I have quite a unusual clinic here. When I started, I just said I'd see anything no one wants to see. So all the weird stuff gets sent to me. So this is a 50-year-old patient with recurrent episodes of diffuse anasarca, severe enough where he's hospitalized for blood pressure support. He gets so hypotensive, he's put on pressors. His tryptase is normal. They do numerous allergy panels that are negative. He has a C1 esterase inhibitor level, which is normal. Finally, someone orders an SPEP, an immunofixation, and it detects a very small monoclonal IgG kappa. Okay. So this is, it's a pretty rare disease. It's called Idiopathic Systemic Capillary Leak Syndrome, otherwise known as Clarkson's disease. This is one of those monoclonal gammopathies of clinical significance, which are near and dear to my heart, meaning it's a disorder associated with an M spike from a small plasma cell clone. It's not myeloma, it's not amyloid, but it's a disorder paraneoplastic related to the small clone of plasma cells. And with this disorder, there's probably about a couple hundred a year, at least in the United States, and they present with recurrent episodes of hypovolemic shock, anasarca. They get hemoconcentration, a low albumin. And what's notable with this is the workups are all negative other than a very faint monoclonal protein. And these patients can be quite ill, and they respond beautifully to IVIG. So it's very important to recognize, like many of the disorders related to this. And if IVIG fails, you can actually treat with plasma cell directed therapy. But it's a rewarding disease to catch and treat. Okay. So, you know, I never know, just to get everyone grouped, we're going to be talking about monoclonal antibodies and some of the papers that I put in this talk, just to get us all grouped. So naked antibodies are just monoclonal antibodies. Then there's drug antibody conjugates that are monoclonal antibodies that are linked to a cytotoxic payload. So it delivers kind of like it delivers a targeted payload of chemotherapy. And then there's bispecific antibodies, which are usually two monoclonal antibodies to two different epitopes that are fused at the Fc portion. And it usually one side's directed to CD3, which brings the T cell to the target. And then the other side is to the antigen, so CD19, like Blantomab. And then there's a lot of new bispecifics right now in multiple myeloma, which will hopefully be approved towards BCMA. Okay, so let's go to a case from my clinic. So this is a 32-year-old female who presents with a large mediastinal mass. It's greater than 10 centimeters. She also has some supraclavicular lymphadenopathy. B symptoms are present. A biopsy shows CD15-30 positive Reed-Sternberg cells. A PET CT demonstrates disease in the mediastinum and left supraclavicular nodes. So she's diagnosed with stage 2B, classical Hodgkin lymphoma. And when you think of early stage Hodgkin lymphoma, we have favorable and unfavorable risk due to many different criteria. So she was unfavorable risk. She has B symptoms and she has bulky disease. So how would you treat? And I always found early stage Hodgkin's, we know a lot about it, but I always found it confusing. So there's many ways to treat this patient. I wish we were in person. I usually try to get interactive with the audience and see how people would treat this. But there are many different approaches. Okay, so this, you know, these are the NCCN, but basically standard right now would be combined modality therapy with ABVD followed by involved site radiation therapy. In this particular case, actually, in a young female with a mediastinal mass, I would actually treat more towards like a RAFL approach using chemotherapy only. So that would be ABVD ×2 followed by a PET. And if the PET was negative, then I would just do 4 cycles of AVD. A lot of people forget that the RAFL study included 40% stage 2 patients. It's not just advanced. So I think that would actually be an appropriate way to treat this patient. But this is a talk on new stuff. So is there any new ways to treat this patient? So let me skip that. So let's talk about Brentuxumab Vidotin, which is a drug that I think a lot of us have familiarity with. It was first approved in the relapsed refractory classical Hodgkin lymphoma. as a single agent, and then subsequently approved in anaplastic large cell lymphoma. And now it's making its way into newly diagnosed Hodgkin lymphoma. So Brentuxumab Vidotin, it's a antibody drug conjugate. So the mAb is to CD30, and it's linked to a payload of monomethyl auristatin E. So it binds CD30. It gets ingested into the cell lysosomes. It's acidified. That cleaves the little linker of the MMAE, and then the MMAE is a potent microtubule inhibitor and kills the cell. So that's how it works. Okay? So this is now approved in the United States in the frontline setting, but not in early stage. So this study was at ASH, I think it's, and also published in JCO, I believe now, that looked at Brentuxumab Vidotin in early stage Hodgkin lymphoma. Okay, and I again, it's early data, but I found this pretty cool. What they did was they took 117 patients with unfavorable early stage. So these weren't like the stage, these were the bad or early stage ones. Okay, and then they treated them with Brentuxumab AVD. So they get rid of the bleomycin. You cannot mix Brentuxumab and bleomycin. You get fatal pneumonitis. Never do that. So they mixed the Brentuxumab with the AVD. They did 2 cycles of this stuff, and then they had 4 cohorts. Okay, one they got involved site radiation with 30, one got 20, and then there was even a cohort where there was no radiation, which to me is the most interesting cohort. So they did 4 cycles of chemo. They had all these different cohorts of radiation, but then they had one cohort with no further therapy. Okay, so what happened? So look at cohort 4. They basically, it was a 97% CR rate. Okay, so in early stage unfavorable with 4 cycles of chemo and no radiation, they nearly got a complete remission rate in everyone. Okay, and then these are the curves, and if you look, you can't tease them apart. So 4, which is the no radiation group, is basically blurred in with the other groups. Now, this isn't definitive data yet. They are running the randomized study, but I eagerly wait the confirmatory study where they're basically going to compare a no radiation-based approach with no bleomycin and just 4 cycles of chemo for early stage unfavorable classical Hodgkin lymphoma as definitive treatment. So, but this is pretty. I'm hopeful with this data. Okay. Okay. So the conclusion from this is a short course of 4 cycles of chemo with a little BV. Had high CR and survivable comparable to the H10 and the Rathel study. Okay, and the addition of radiation to the short course of chemo didn't seem to improve outcomes. Okay, so again, they're running the confirmatory study. Okay, that's the Hodgkin's for us. That's the easy stuff. Let's get to a little bit harder malignancies to treat. And I see a lot of this. This was a patient I saw a year ago. It's a 78-year-old male. Okay, and presented with fevers and lymphadenopathy above and below the diaphragm. They also had this nodular rash that was everywhere. It was ulcerating. It was pretty unpleasant, and the patient was in a lot of pain from this. A biopsy revealed a peripheral T-cell lymphoma, NOS. So this wasn't a cutaneous lymphoma. This was a systemic PTCL that spread to the skin. So stage 4, CD30 labeled 20% of the atypical cells. So how would you guys treat a 78-year-old with stage 4 aggressive peripheral T-cell lymphoma? So he was fit, you know, this was a fit 78-year-old, but this is a hard situation. So what did we do? So just a little bit on peripheral T-cell lymphomas. They don't do well. You know, we do good with B-cell lymphoma. We don't do so well with peripheral T-cell lymphoma. When I teach the fellows and residents, I basically say peripheral T-cell lymphoma, there's anaplastic large cell lymphoma, ALK positive. Those do okay. Those do more similarly to DLBCL. All the other ones have roughly 20 to 40% long-term survival. And then for some of the rare subtypes like hepatosplenic enteropathy, the survival is less than 10% at 5 years. Okay, so we need to do better. Why can't we do better? Well, we don't have a lot of antibodies like we do in DLBCL. It's rare. It's only about 10 to 15% of non-Hodgkin's lymphomas. And there are many, many subtypes with different disease biology. So it's hard to study. Okay, so this was a practice-changing study, at least for me. And that's why I'm presenting it. So this is the Echelon 2 study So this was a multi-center phase 3 randomized double-blind, double-dummy study in peripheral T-cell lymphoma. So what they did was they included all histologies of peripheral T-cell lymphoma. The FDA, at least for American approval, they mandated that there'd be a lot of anaplastic large cell lymphoma included in the study. So the majority of the patients in the study had ALCL, but they did include other histologies. To be eligible, you had to also have greater than 10% CD30 expression by IHC on the neoplastic cells. Okay, and they couldn't have peripheral neuropathy. This was a fair study. Some studies are not fair, which we'll talk about in a second. But this study I liked. They basically compared to the standard of care, which is CHOP, which is the standard of care, to Brentuxumab CHP. So they got rid of the vincristine because of the overlapping toxicity between vincristine and Brentuxumab Vidotin. So it's not a 5 versus 4 drugs, it's a 4 versus 4, a nice even swap. And their primary endpoint was progression-free survival. Their secondary endpoint was overall survival. The dosing is the same as CHOP, but they get rid of the vincristine and then they added Brentuxumab at 1.8 mg per kg, and this is given every 3 weeks, okay? So again, what I highlight here is that the majority of the patients had anaplastic large cell lymphoma, but they did include other varieties, including angioimmunoblastics, PTCL and OS, and then there were very small numbers of adult T-cell leukemia, lymphoma, and enteropathy. Okay, so question 1, is progression-free survival improved? And yes, it was. Okay, so by swapping out vincristine and replacing with Brentuxumab Vidotin in CD30 positive PTCL, progression-free survival was improved. But this was the money right here. The overall survival was also improved. And for the first time ever in a randomized study in peripheral T-cell lymphoma, we were able to show an overall survival advantage, okay? And this is still holding true at follow-up. So this is where my practice changed. And what I'll say is it gets a little sticky with anaplastic large cell lymphoma. It's a no-brainer. This is the regimen to use. In a PTCL with good CD30 expression, I'm going to use it. Now, what about the angioimmunoblastics and those not so much? It's unclear. And if you ask different investigators or T-cell lymphoma doctors, some do it, some don't. It's a discussion with the patients. But at least we now have one study that we have improved upon outcomes with CHOP. And I will say, toxicity, it's the same as CHOP. There's no more febrile neutropenia. The neuropathy is the same. It's not any really different to give than CHOP. It's more expensive, though. It's a lot more expensive. So that is a critique. Brentuxumab Vidotin is not cheap. Vincristine is cheap. So that would be a critique of Brentuxumab Vidotin. Okay. Let's transition to another lymphoma. How much time do I got? 15 minutes. I'm going good. So this is another patient I saw right before this talk I put together. So 70-year-old female with stage 3 non-germinal center diffuse large B-cell lymphoma. She was a double expressor, meaning she expressed BCL2 and MYC. She was treated with R-CHOP. Then she unfortunately relapsed 2 years later. For numerous reasons, she was not a candidate, at least at our center, for CD19 autologous CAR T cells or an autologous stem cell transplant candidate. So she's not fit or deemed eligible for cellular therapy, at least in my clinic. What do you do? So there's now lots of choices. It got hard. It used to be not so many choices. So the NCCN is fairly useful. It's not super useful here. They basically say if you can't do CAR T or auto transplant, see suggested second line regimens, and they got all sorts of second line regimens now. So there's Polatuzumab Vidotin plus bendamustine and rituximab. Polatuzumab is an antibody drug conjugate to CD79B. There's tafasitamab plus lenalidomide. Tafasitamab is a CD19 naked monoclonal antibody. Okay, and then there's Tuxemab tesirine, which is a CD19 antibody drug conjugate, and then there's selinexor, and I won't talk about selinexor. It's useless in this space. But the point is that there's now, at least in the United States, 4 novel therapies outside of chemotherapy approved for non-CAR T auto-eligible patients. So I'm going to go over just one of them that I found most interesting, okay? So how do you choose? So there's no comparative studies, okay, at least yet. There is one randomized phase 2 where they did BR Pola versus BR. It was underpowered for definitive conclusion, but it showed BR Pola is better than BR, although I would argue that BR is not much something I use too much in relapsed DLBCL, but that maybe is the best data we have, okay? So I'm going to go over tafasitamab lenalidomide. It's a drug that I don't think a lot of people have super familiarity with, and in this particular patient example, I think it's actually a very reasonable and good choice. So it's a CD19 antibody, and it's naked, and they combined it in the study with lenalidomide, which has all sorts of activity, both immunomodulator, and it's got direct cell death cytotoxicity. So the L-MINE study, this was a phase 2 study to assess the safety and efficacy of tafasitamab in combination with lenalidomide. So they basically took patients, just like in the example, that were not eligible for intensive therapies. And they gave tafasitamab, which is given weekly for the first 3 cycles, and then every 2 weeks, basically indefinitely for a long time. And then they combined with lenalidomide 25 milligrams days 1 through 21. Okay. And what I find impressive is, so when I'm consenting patients or discussing, all these new drugs have about 30 to 40% CR rates. So not like amazing. But in the patients they work, especially this drug, the duration of response is years. So it can really work well. And in a setting where a relapsed elderly patient with DLBCL used to be pretty dismal, with, you know, therapy that's not cytotoxics, that's reasonably well tolerated, you can get fairly durable responses. And here's the curves. This is in those who responded, okay? And the blue is those who had 2 lines, and the orange is those who had 3 lines. But the bottom line is at 4 years, or even close to 5 years, there's a reasonable amount of patients that are still in response. So, you know, at least what I used to think of as a dismal situation, now I have options that can offer fairly reasonable disease control. Dare I say cure? I don't know. Now, in patients that are eligible for CAR T, I'm not giving a CD19-directed therapy, so I wouldn't give this drug. But for those patients that are not, I think this is a reasonable option. It's also super expensive. I have no control over that, but it does seem to work in those patients, okay? So this has changed my practice a little bit in the relapsed DLBCL setting. Okay, so I don't need to belate the point. I think this is a highly active regimen, very expensive, but it's useful in those populations that you can't take to more aggressive therapies, okay? Now, if you follow me on Twitter, I like talking about myeloma. I'm full disclosure, I don't think I'm an expert in, you know, I treat a lot of myeloma. I wouldn't call myself the world's expert in myeloma, but I like talking about myeloma because I see a lot of it, and it's a confusing disease. There's lots of choices, and we don't know what the hell to do half the time. So, so the stages of myeloma therapy, just to get everyone grouped together, if you don't see a lot of myeloma, there's the first thing when I see a new patient with multiple myeloma, are they transplant eligible or not? In my practice, because I'm a transplanter, the majority are eligible for transplant. And if they are eligible, transplantation, autologous should be somewhere in their treatment course. It could either be upfront or delayed until relapse. For the IFM09 study, there's no hindrance in overall survival. If you do it up front, progression-free survival, of course, is longer with an upfront transplant. So there's induction therapy, which you do with some sort of regimen, then consolidation, which can take the form of a transplantation in those eligible, and then followed by maintenance therapy, which usually is single-agent Revlimid, although some opt for more intensive maintenance regimens with proteasome inhibitors and IMiDs for those with high-risk disease. So let's look at the ineligible. You know, some of this, I know I was supposed to talk about novel stuff, but I'm talking about stuff that I think is super important, and again, that has maybe changed my practice a little bit. How do we approach the ineligible for autologous transplant that are newly diagnosed? Well, this is how I used to do it, okay? So the SWOG 777, OS 777 study, did RVD versus RD. It was randomized. There was an overall survival advantage with RVD. So for the transplant ineligible patients, I was giving everyone RVD. Okay. Keep in mind, when you get above 75 to 80, the RVD can be kind of hard, especially the Velcade with neuropathy. So I was very quick to de-escalate the Velcade, if not drop it, because, you know, neuropathy sucks. You can't, it's hard to, you give them gabapentin, they barely get better. And it's a complaint in clinic that I find very frustrating for myself, and I'm sure for the patients. So I'm very quick to de-escalate. So how have I changed as of recently? So let's talk about daratumumab. So this was approved in the relapse space first as a single agent, and then per the in the relapse setting in combination with Velcade-Dex and Rev-Dex. So this is a monoclonal CD38 to IgG to CD38 on the plasma cells. Okay, so let's look at the Maya study. And I've now changed my practice using this study, this regimen more for my transplant ineligible patients. So this took daratumumab, lenalidomide, Dex versus lenalidomide, Dex. So they got rid of Velcade. Now, I think someone could astutely point out that the control arm's kind of weak. Lenalidomide, Dex, at the time the study was opened, that was considered, the SWOG hadn't resulted yet. I still contend it's a crappy control arm. It is what it is. That's what they did. So Dara, Rev, Dex versus Len, Dex, okay? And the bottom line is they showed an overall survival advantage. And look at those curves. It's 5 or 6 years. There's still half the patients are in remission. That's amazing. I mean, you got a 76-year-old patient with myeloma. Once they relapse, it's pretty bad. You can give them Dara, Rev, Dex. They don't get the neuropathy, and they can have a super durable first remission with a high quality of life. That's important to me and the patient. Therefore, I am using more of this. Now, is it better than RVD? I don't know. They didn't do that study, and they never will. But there's definitely less neuropathy, and I do think it's easier to give. There are infections with daratumumab, pneumonias, immunosuppression, but I do think it's easier to give. And it's super expensive also, but I do think it's an easier regimen to give. There's a survival advantage to RD. There's no Velcade, so I've been using it. Okay. Let's go into the relapse, and then I'm almost out of time, so I'm going to finish fast. I promise, guys. 65-year-old with IgG kappa, multiple myeloma, complicated by lytic bone disease, diagnosed 5 years ago, treated with RVD, auto transplant, Rev maintenance, relapsed 2 years later, got Dara, Velcade, Dex, relapsed a year later, got Kyprolis, Pom, Dex, now presents with a rising M spike. So this is the classic myeloma patient that has unfortunately progressed through just about everything, okay? So we got a lot of treatments approved for myeloma. So how do we use some of these new stuff in the space? So new drugs for myeloma. There's actually now 6. I didn't update this. Cilta-cel was just approved by the FDA in the United States, a new BCMA-directed CAR. We already had Ida-cel, a BCMA-directed CAR. There's selinexor, which is a nuclear export inhibitor. There's Blantomab, the BCMA antibody-drug conjugate. Melflufen, which is, quite frankly, a horrible drug, which has now been removed from the U.S. market due to the increased death signal. So I won't talk about Melflufen. And then there's Venetoclax, okay? So real quickly on Blantomab, people are starting to use it. Blantomab is a BCMA-directed antibody-drug. Someone's not on mute.
Sponsors.
It's a BCMA-directed antibody-drug conjugate, and it's approved in the relapse setting. The activity is modest. There's about a 30% response rate. And the big issue with this one is ocular toxicity. 70% of patients get a keratitis, and it can be grade 3 or 4 and 30%. So patients have to see an eye doctor every 3 to 4 weeks. So it's pretty tough to give, at least in my experience. Okay. But I do want to focus on Venetoclax because it's coming up quite a bit in myeloma, and there's some questions on how to use it. So Venetoclax is not approved, at least by the FDA, or I think any agency in the treatment of multiple myeloma. But there was the randomized phase 3 Bellini study, which looked at Velcade Dex versus Venetoclax Velcade Dex. Again, a recurring theme. The control arm is not so good. Velcade-dex is a weak control arm for a randomized study in the relapse setting. That's what they chose, and they combined it with Venetoclax. The Bellini study had translocation 1114, but this was in all comers, okay? And I like this study. Well, the result wasn't good, but it shows an important point. The progression-free survival with Venetoclax was superior. Look at that blue line. It is way higher than the placebo. But if you look at the Kaplan-Meier for B, the overall survival was worse. So here's an example where progression-free survival is superior, but overall survival is worse. Take-home point, Venetoclax added a lot of toxicity and early infectious deaths, okay? So we can't hang our hat on progression-free survival in myeloma, okay? So there's a big stop sign. Now, they then went back and looked at the translocation 1114, and the signal for Venetoclax in translocation 1114 is even better in terms of PFS. I am not using this drug yet. They are running a randomized study just in 1114. I don't think it's fair yet to use this drug when a randomized study showed a death signal. I'm waiting for the results of this study. I do suspect it will be positive for the translocations 1114, but it's still too early, okay? I'm gonna skip that. We're gonna, real briefly on selinexor, I'm quite critical about it on Twitter. I'm critical of it because of this study, and it's really just hopes that we move forward in the field of myeloma. Basically, I don't use selinexor in myeloma. I just don't think they've shown a place where I should use it. It's approved in the United States. The Boston study, which started enrolling in 2017, had a control arm of Velcade-dex versus selinexor Velcade-dex. In 2017, Velcade-dex was not the standard of care for relapsed myeloma. Numerous studies had shown benefits to triplets compared to Velcade-dex. So any results you get from this study compared to a standard of care that we don't really use. So, it showed selinexor was better, but it showed it was better than something I don't use, and it was only modestly better. So right now, I don't know the place for selinexor in myeloma. I'm waiting for the trialists to show me where I should best use it. Okay, that's where I'm running out of time. So that's the I finished kind of fast, but this was just to show that in our guidelines, Velcade-dex was it's way at the bottom. That was useful in certain circumstances. We have all these other combinations to use. So I think the place for selinexor would be someone who's really a patient who's seen just about everything, who has no clinical trial options, and with a nice consent process, it's maybe not unreasonable to try a selinexor-based combination. But I would not use it before anything else until we're shown data that is in fact better than anything else. Okay, and that finishes my talk. It was kind of a whirlwind of things that I thought important, that at least changed my practice over the last year or so. I'm here for any questions, and thank you for having me.
Thank you so much, Dr. Aaron Goodman. Excellent updates on interesting disorders. We'll move on to the next talk and leave the question at the end, if that's okay.
Okay, the second speaker, it's a great pleasure for me to introduce Dr. Bashaglibo, who is the head of the Division of Hematology and Stem Cell Transplant at Genova, Italy. Dr. Bashaglibo has conducted several clinical trials in patients with aplastic anemia and in patients with undergoing allogeneic transplant. His main interests are bone marrow failure, graft versus host disease, and related complications, and graft versus leukemia reaction. He has also been interested in treatment of viral infections post bone marrow transplant. Dr. Bashaglibo has served as a board member of the European Transplantation for several years, and as a secretary, then chairperson of the Aplastic Anemia Working Party, and then as president from 1998 to 2008. He served as president of the Italian group of bone marrow transplantation from 2002 to 2005. Professor Bashaglibo has published over 500 articles in peer-reviewed journals, and he's a member of several national and international hematology societies. Professor Bashaglibo is going to talk about primary graft failure after Haplo BMT causes and treatment. Welcome, Prof. You can start.
Good morning. This is Andrea Bacigalupo, and I'm talking from Rome, Policlinico Gemelli. The title of my talk is Primary Graft Failure After Haploidentical Transplant, Causes and Treatment. So what is primary graft failure? A patient who never achieves a granulocyte count of 500 neutrophils, let's say by day 30, and has absent or very low donor chimerism, let's say between 0 and 30%. Usually it is 0 when the patient does not engraft. And this condition exposes the patient to a high risk of transplant-related mortality. This is a paper by the CIBMTR looking at primary graft failure after unrelated transplants. They analyzed 14,000 patients, of whom 6%, so this is the first message, 6% developed primary graft failure. And as you can see, 817 did not receive a second transplant. Of these, almost all were dead very rapidly. 99% of the non-transplant died. 122 patients received a second unrelated transplant at a median interval of 48 days, 18, 126. 98 from the same donor, 24 from a different donor. The outcome of these patients is here. The engraftment rate was 76% at 100 days, but the mortality was 75% at 100 days. And the 1-year transplant mortality is 85%. So the survival at 1 year of these 122 patients was 7%. So primary graft failure after an unrelated transplant is 6%. A second unrelated transplant is, I would say, a disaster. 86% transplant mortality, 7% overall survival. Why? Well, perhaps time to find an unrelated donor or a second donation. Perhaps the conditioning regimen. I don't know. What happens after a haplo transplant? So primary graft failure after haplo has been described in the ATG-based platform of the Chinese group, between 7 and 15% primary graft failure. Also in the ex vivo T-cell depletion, less, but these are all children with myeloablative regimens, and also very low in the Perugia platform using Treg T-con cells. And the post-transplant cyclophosphamide-based haplo primary graft failure has been reported between 7 and 15%. The MD Anderson in Houston has published 122 patients in whom the rate of primary graft failure was 18%, rather high. They also described a role of donor-specific antibodies. Patients with antibodies to the donor had a rate of 32% primary graft failure. Patients without antibodies against the donor had a primary graft failure rate of 4%. This is the outcome of the patients in Houston after haplo with or without primary graft failure. So you see again exactly what we have seen in the unrelated donor transplants, also in the haplo transplants, the outcome after graft failure is a disaster. So this is what I have summarized here, that also after haplo, it seems that primary graft failure, at least in these published papers, is a real problem. And the question is, well, can we do better than this? So this is a slide you have seen, I suppose, many times. This is the TBF regimen we use for haplos, but also for other transplants. So this is 2 days of thiotepa, 5 milligrams times 2, so that's 10 milligrams. It's 3 days of busulfan intravenous, 3.2 milligrams per day, and 3 days of fludarabine, 50 milligrams meter square per day. It is a nice, compact, short 5 days conditioning regimen. In the haplo setting, we use unmanipulated bone marrow. And as you know, we have been using cyclophosphamide on day 3 and 5, and cyclosporin starting on day 0, and mycophenolate. This is all published. In patients over the age of 60, we usually reduce the dose of busulfan to 2 days, and over the age of 70, we reduce the dose of busulfan to 1 day. But we still use the 2 alkylating agents in reduced doses, but it's still 2 different agents. In young patients with acute lymphoblastic leukemia, we still use full dose TBI up to the age of 45, 12 grays, and fludarabine 120 milligrams. And then the bone marrow unmanipulated cyclophosphamide, cyclosporin, mycophenolate is the same. So I would call this myeloablative haplo transplants, and I'm going to show you 503 patients grafted between 2010 to 2018, and this has been published recently last year. So the majority of patients received thiotepa, busulfan, fludarabine, and a small number of young patients with lymphoproliferative disorders received the flu TBI regimen. And as I told you, all of them received unmanipulated haplo bone marrow. So we have 484 engrafted and 19 with primary graft failure. So this is 3.8%. So the first message is, with this regimen, with a myeloablative regimen, the incidence, the rate of primary graft failure is low. Could we find differences between the engrafted and the non-engrafted? Not really. Age was the same. Donor age was the same. Diagnosis was the same. There was a slight increase in the myelofibrosis, so 20% versus 12, but not reaching significance. The median cell dose of unmanipulated bone marrow cells was exactly the same. And as you can see, we had engraftment with 1.1, and we had rejection with 5.3 cells times 10 to the 8th per kilo. The follow-up is also rather similar, which is the other message I would like to give you later. So here we have 19 patients with primary graft failure. There was only 1 patient out of 74 receiving TBI, so that's 1.4%. There were 6 out of 213 receiving the 3 doses of busulfan, so that's 2.9. There were 11 out of 208 of 2 days of busulfan, that's 5.3. And there was 1 out of 8 receiving 1 day of busulfan, that's 12%. So you can see you go from 1% with full dose TBI to 12% in the very small number of patients with the lower dose of busulfan. So the first message is that we had 3.6 rejection rate with 2 alkylating agents. This is very important. Why is it important? Well, in another analysis we have published last year in the American Journal of Hematology, in myelofibrosis, which is a difficult disease, we have compared 42 patients receiving 1 alkylating agent, either melphalan, busulfan, or thiotepa with fludarabine, versus patients 78 myelofibrosis receiving 2 alkylating agents, thiotepa and busulfan. And this is all donors, siblings, unrelated, haplos. And this is the message I would like to give to you. On day 30, if you get only 1 alkylating agent, you have only 51% of patients with full donor chimerism versus 87% if you give 2 alkylating agents. Look on day 60, we have 93% of the myelofibrosis patients with full donor chimerism versus 13% if you only use 1 alkylating agent. And the same is on day 90. So 2 alkylating agents will allow for a stronger engraftment as compared to 1 alkylating agent. The combination could be thiotepa busulfan or thiotepa trisulfan or thiotepa melphalan or busulfan melphalan. I mean, you could choose what you want, but I think it is very important to use 2 alkylating agents and not 1. If you do this, the overall rejection in the haplo is very low, 3.6%, which I think is very low. There's a trend I have shown you for a role of the intensity of the conditioning regimen, and we could find no other predictive variable. What about donor-specific antibodies? Well, we detected DSA in 8 out of the 15 patients who rejected and were tested. So we found antibodies in 50% of these patients. So what happened to these 19 patients? Well, these patients received a second transplant with the Baltimore regimen, cyclofludarabine, TBI 200, cyclophosphamide, the Baltimore regimen original. Peripheral blood was used for all patients. 13 of the 19 were the same donor, and 6 were a different donor. The interval, very similar to what you have seen for the first slide I showed on unrelated, 42 days, between 33 and 66. So we were very fast in giving a second transplant. 14, so that's 73% of patients engrafted with the second transplant. 2 out of 5 did not engraft and were rescued with an unrelated transplant. So the total engrafted is 16 out of 19. So we had 84% of patients who engrafted after a second transplant. 13 of 19 are alive at 1 year. 1 died of relapse, 4 of infection, 1 of graft versus host disease. Engraftment day 15 for neutrophils, day 35 for platelets, and survival is shown here. So this is the survival of the 484 patients who engrafted, 74% at 1 year. And this is the survival of the 19 patients who failed to engraft as a primary graft failure, but then were rescued with a second transplant. And this is not different. So survival at 1 year. So this is very different if you compare this with what I have shown you from the MD Anderson in Haplo and from the CIBMTR in unrelated. So primary graft failure can be rescued with a second Haplo Overall mortality, we lost 5 out of 500 patients receiving a myeloablative regimen or TBI. So we lost less than 1% patient. But a patient with less than 100 neutrophils on day 25 and mixed or autologous chimerism is prepared for a second peripheral blood haplo immediately. And we do not select donors on the basis of donor-specific antibodies when we use a myeloablative conditioning. What about these DSA? So 8 patients were DSA positive, were retransplanted, and 7 out of 8, so 87% of the patients with antibodies engrafted with a second transplant. 4 of these were from the same donor. 7 patients were DSA negative, and 5, 71%. So there was no difference in the engraftment of the patients with or without. There were 4 patients in whom we did not have the data on DSA. So my personal opinion is that donor-specific antibodies do not seem relevant for a second engraftment in this condition after a first myeloablative conditioning regimen, and with the Baltimore as a second conditioning regimen. So primary graft failure is a rare event if you use a myeloablative regimen. It is rare if you use 2 alkylating agents. If in this case you do not need to test for donor-specific antibodies, but if a patient has a low count, please remember to prepare the patient for a second rapidly peripheral blood haplo transplant. And this second haplo will result in 66% 1-year survival, which I think is excellent. I would like to spend the last minutes on poor graft function. This is low counts, either primary or secondary, but with full donor chimerism. So the difference between primary graft failure and poor graft function is that this is a patient who has engrafted, but he doesn't have counts or platelets. And I'm going to show you an analysis of over 1,000 allogeneic transplants performed in these 20 years. So 1/4 of patients have less than 50,000 platelets on day 75 after an allotransplant. 9% have less than 20, and 17 have between 21 and 50,000. So have things changed with time? No. Here you see the first decade in orange and the second decade in yellow. And you can see the proportion of patients with less than 50,000 platelets is exactly the same on day 30, on day 75, on day 150, and also 1 year after transplant. So we have exactly the same rate of good hematologic recovery after an allogeneic transplant. What are the risk factors? Well, Gvhd, age, older age, a diagnosis of myelofibrosis, and HLA mismatch all combine to produce poor hematologic recovery. Stem cell source bone marrow peripheral blood has no effect. Does this have a role on mortality? The answer is yes. Look at the platelet recovery in quartiles. So less than 48 is the lowest 25% quartile. Transplant mortality is 30%. In patients with the upper quartile, over 170,000, always on day 75, 300 patients, mortality is 3%. So mortality is 10 times more if you have less than 50,000 or more than 170,000. Incredible data. I mean, this is the, and of course you could ask the question, well, is this because the patients have low platelets, or are low platelets a mark of toxicity? Anyhow, we certainly can say they have a strong influence on transplant mortality and survival, which I did not show you. And what can we do to improve graft function? Well, we published a paper in 2015 in which paper we analyzed 41 patients with prolonged poor graft function and complete chimerism, and we infused CD34 selected cells from the same donor, no conditioning, no change in Gvhd prophylaxis, median time 140 days from transplant, 48, 370, median time to recovery 100 days. And here you have 75% of these patients who recovered after infusion of CD34 selected donor cells. Eltrombopag is another option. We published this paper last year in the International Journal of Hematology. We analyzed 48 patients, median age of 55, from matched related, matched unrelated, and mismatched related donors. Eltrombopag was started at a median of 134 days, 71,800, given for a median of 4 months, between 25 and 100 milligrams. And again, we had a very similar response as compared to the cells, 77%. And here you have the response with Eltrombopag, and here you have the response with the CD34 selected cells. They look almost identical, really incredible. So 25% of patients have low platelet counts early after transplant, and this has not changed with time. Low platelet counts are predicted by, I showed you, age, HLA diagnosis, and Gvhd. Eltrombopag and CD34 boost are both promising measures with an overall response of 70%. A randomized trial of Eltrombopag versus placebo is, I think, personally, is urgently needed to prove that Eltrombopag improves hematologic recovery in patients with poor graft function. And I would like to thank you for your attention, and of course thank all the people who work in the unit, both in Genoa and in Gemelli, Rome. Thank you very much.
Thank you, Professor Bashagalibo. Very nice and interesting presentation. So
we'll move on to the third presentation. It's my great honor to introduce one of my dear mentors, Professor Aaron Foley, who's a professor of pathology and molecular medicine at McMaster University, Canada. He is the director of the stem cell lab in Hamilton Health Science in McMaster University. He served as the president of the Canadian Blood and Marrow Transplant Group and served in many organizations as a member and active researcher with many publications in peer-reviewed journals. He is active in research including multiple myeloma, lymphoma, and CAR T cells. He will talk to us about CAR T cell therapy, changing paradigm in the treatment of relapsed refractory diffuse large B-cell lymphoma. So very nice to see you, Ronan, and welcome. Go ahead.
Thank you very much, and a real privilege to join your Congress. I agree, the relationships over decades really at cell therapy centers in Canada and all our great collaborations have been very much cherished. That's nice. These are my disclosures. And tonight, I briefly want to go over CAR T therapy in 3L diffuse large B-cell lymphoma at a commercial level, kind of to identify some of the challenges in the real-world setting, and potentially to improve efficacy. Some of the things we learned in our own center, now being open for 2 years, looking at CR rates and at least 6-month PFS and ideally 12 months. So what I can say is, after you've gone through the process of opening up for CAR T and the onboarding and getting set up, at some point, probably in your first year, you have to step back and look at some metrics. And in my mind, the first metric is response rates. And if you take real world evidence and the Juliet trial, in this case, I'm talking about the Tisagen Lucil product, you want to be at an overall response rate of about 57%, and ideally a CR rate, metabolic CR rate by PET of 45% in the patients you're treating. And to do that really is a blend of little things that you have to put together. What we learned was it was a bunch of little things putting together to get to these kind of numbers. And it comes to patient referrals, which really should be early as possible. And that requires an established communication with the referring institutions. And I can say I was a bit remiss from the beginning that we were really focused inward on our center, how to treat CAR-T. But in reality, the referring institutions are critical and really should be at the table from the get-go for deciding when a patient gets referred, as well as taking care of them after day 30. We like to have complete referral packages pretty much ready to go for the patients, including any biopsies, echoes, PFTs, etc. And if possible, a consideration of a CAR-T patient, try to avoid any therapies until you've collected the lymphocytes so you don't get caught in some washout numbers. And you want to maintain the integrity of the lymphocytes. The next is patient selection, and as we all know, ECOG, LDH, metabolic tumor bulk, double hit, MYC expression, rapidly growing, chemorefractory, never in remission. These are all the bad features of patients. And certainly at some point, a patient just may be too unstable, where we do not recommend CAR T-cell infusion, because as we know, it takes time to prepare and to get the patient ready. I can't overstress timing, and I have questions about bridging. CAR T management, of course, is a very important thing. And I always wonder, for patients who have these terribly hyperinflammatory situations, how well can the CAR T cells perform? Avoidance of steroids with the TISA product. And then finally, can we improve the CAR T products, potentially higher cell doses, avoiding exposure to certain drugs? And the big one, avoiding the out of spec, which really creates more delays and potentially adds to problems. So the first thing I'd say, and I'm sure folks know, is that, again, once you've set the table in your institution, speed wins. And, you know, often these patients are unstable, and getting to the cell infusion as quickly as possible, including the time for manufacturing, is critical. So we really, from the initial consult, we sign the patient up on the first day and get things going as soon as possible. Now, when you get a CAR T cell referral, there's quite a list of things you have to go through, including whether treatment needs to be delayed because of just too progressive disease or compromise of organ function. What are the organs like? There's no restriction on age, but patients should be able to receive standard systemic treatment, which would include a platinum agent. Ineligible or failed autologous transplant, no prior T-cell or T-cell immunotherapy, no uncontrolled infections, no prior stem cell, if prior stem cell, no active Gvhd, no active CNS. You're looking at LDH, rapidity of growth, MYC expression, risk of bleeding, and then ultimately, what's your sense about the T-cell fitness? So it's quite a complicated set of considerations that go in when you receive a referral for CAR T-cell therapy. And we know some of the patients that don't do well, rapidly progressing without the option of bridging, creatinine clearance less than 30, issues about fludarabine dosing. ECOGs 3 and 4 really have not done well. And the ECOG 3 and 4, remember, you're looking at it at the time of the initial consult, but perhaps more importantly is prior to lymphodepleting therapy. Has the patient changed? Infections? And then, as we said, this all takes time, and it's perhaps one of the limitations of CAR T therapy is you have to wait to produce the cells. Now, to get a sense of where we think we should be, in Atlanta, Dr. Landsberg from UPenn presented the CIBMTR registry for the Tisagen Lucil product. And essentially, it's the real-world evidence, although it's not at a clinical trial level, it does provide the numbers and a sense about what's happening. And this was a study looking at the States, Israel, and Canada. And you can see there was an efficacy set and a safety set that were looked at with fairly good sized numbers. Now, what this study ultimately was looking at was, in the real world, how many of these patients would have been Juliet eligible. And so what I can say about that was, when you compile all these countries and look at it through the CIBMTR data, actually 67% of patients would not have been eligible for the Juliet pivotal trial. And largely because of ECOG, 20% out of range, but the majority was comorbidities. So medical comorbidities would have been the thing that kept them off the trial. And again, getting back to where we think we should be with response rates when you start into this, interestingly, whether they were eligible or ineligible, the response rates, including overall response, which should be around 57 to 60%, and CRs, which should be somewhere between 41 and 44% in this population. So that kind of sets the mark for what you should be striving for, in my mind, but based both on clinical trial data as well as CIBMTR. Now, the one thing that you can sort of be less concerned about, especially with the 4-1BB products, is CRS. And interestingly, in this study, the CIBMTR, even the Juliet ineligible patients had very low rates of CRS. And so compared to Juliet, which of course did use a different measurement, bad CRS needing pressors or to the unit was only 8%. And of course that sets up for potentially outpatient patients or outpatient treatment, given this pretty low level of grade 3 CRS. So really the toxicity, I think, is dealt with. I think perhaps the lower level of CRS is perhaps more liberal use of tocilizumab, but it really comes back to the efficacy. Are you getting to the efficacy that kind of fits more with what's being seen worldwide? Now, just to quickly mention toxicity, and of course some of the other products, and with TISA, again, bad CRS about 4.5%, lasting about 4 days, median onset early on, neurotoxicity, severe neurotoxicity, just 5%, and the median onset is on about day 8. Not a lot of steroid use for the TISA, and that compares with some of the other products, of course, Lyso 4-1BB, but also AXI, and AXI with the cohort 6, where corticosteroids were used essentially at the time of infusion. And you can see that the use of steroids with AXI, the severe rates do come down, but there does seem to be a prolongation, 19 days, of those side effects. And as we all know, when you treat, neurotoxicity is the one quite concerning side effect to have. Now, getting back to the CIBMTR, again, it didn't matter if you were Juliet eligible or ineligible. The responses were about the same. But again, you can see on the right here, for those who achieve a CR, either on day 30 or on day 90, complete metabolic response by PET, they do much better. And so again, I think that looking at response rates, once you've started up your program, is the first step. And I think the PFS data will follow from it, because if you get to a metabolic response, they often hold and the patients remain stable. Just a bit more real world data also presented at ASH. This was from the Galtamo Italian groups, 12 centers. And in this analysis, they had access to both AXI and TISA. And so they looked at about 300 patients looking for comparison. And you can see essentially the products performed about the same at the end of the day. that perhaps the ASHC, which is in red, perhaps an earlier response, but eventually they kind of end up in the same place. But the important thing that came out of this study was that with multivariate analysis, ECOG 2 or more at the time of lymphodepleting correlated with the worst outcomes. So that's certainly the time the patients come in for their fludarabine is a very important time to carefully assess them, and especially if the ECOG has fallen off, they may not do well. Now, in terms of the clinician's perspective, as we know, we're getting good patients and bad patients, and not bad patients, but challenging patients. Patients on the left, young, few comorbidities, low tumor bulk, not growing, an early referral, don't have a lot of disease, great ECOG, fit T cells, low inflammatory state, and they have a caregiver because we do outpatient. And that compares to the other side. And of course, keep in mind, sometimes the patient starts on the left, but then can shift over to the right. In terms of efficacy and safety, there are parameters now that we use in practice to kind of predict for efficacy and safety. Again, I think the earlier the referral can be in that good working relationship with referring institutions to identify these patients and start to have discussions early in their treatment history, kind of hopefully prevents from patients becoming too far gone with some of these parameters that we know contribute to worse outcomes. And again, just to get back to the early referrals, which I think is critically important, again, you can sort of see the journey that large cell lymphoma patients take, being potentially refractory and then considering for an autograft, and then potentially relapsing after an autograft. So again, figuring out specific time points, milestones where you might consider CAR T cell therapy so that the patients can get there as soon as possible. Now, in Juliet, we did some analysis. Nothing really came out about predicting patients, but when I'm assessing a patient for CAR T, there are just 4 things I really look at. One is whether they've been in remission, which I think is a good thing, or if they're truly refractory. The number of lines of therapy, you can see once you get beyond 4, whether they're a double hit or is an issue, and how much tumor volume is there metabolically. And the more bulky, the worse. So again, within the referral, I'm sort of thinking about patients in this line. We do know, this was presented 2 years ago at ASH, we do know that MYC overexpression by immunohistochemistry does seem to be associated with a worse outcome in these patients, perhaps not surprising. Now, in terms of our referrals, as I said, we do like to have everything pre-packaged so that the local referring institution is kind of getting everything ready to prevent any delays. So when the patients do come, these tests that are required, at least here in Canada, to be eligible for CAR T are already completed. The washout, as I said before, if a patient is considered for CAR T, don't do anything, just make the referral, because some potential drugs that you could be using prior to CAR T may handcuff you into having to wait for a washout, which creates more delays. Now, I think as you know, and I've talked to folks in Saudi, collecting lots of cells with the Tisagen product is something we learned, and it's something I advocate for, not just because out of spec, which it seems to occur with the lower doses of CD3 cells. So in our center, we do put in a central line. We do a fairly large volume collection so that we're aiming for at least 4 × 10⁹ cells, and sometimes more. Has introduced some problems with what we do with the excess ones. Bridging, I'm not going to spend time on. Obviously, it's something you do have to do for patients to kind of keep things going while they wait, but I don't have a great sense of if bridging is doing good or bad. It's necessary, but certainly when you look at some of the data from the ASHC product, overall survival does seem to be poor when you have to bridge. And again, I don't know if it's just patients that don't need bridging do better. In terms of CAR T toxicity management, I won't go into that too much, but obviously centers have become quite good at managing these patients. Just a few points. I don't use anti-cytokine therapy for ICANS. If there's no CRS, you might make it worse. 2 to 3 doses of TOSI. The CRP will fall, but there still may be a cytokine storm going on. And so anti-IL-6 drops the CRP, but you may have to think about HLH and other things if the patient stays sick. 72 hours of fever, you may end up giving TOSI. I do think there's differences in corticosteroid threshold. I tend not to use steroids unless it's ICANS for the TISA product. And of course, algorithms in the center are important. Now, finally, in terms of outpatient, this is something we set up for from the get-go. And of course, not every patient can be outpatient, but many can. So it improves the capacity for newer CAR T therapies that are coming through, less inpatient resources. It might be a better patient experience, I'm not sure. Reduced exposure to infections, and it might save money. Of course, what I am talking about, though, is patients come into our city, they stay in a hotel, and they're making daily visits. And it's very much similar to the outpatient autographs that I'm sure many centers are doing. There's a lot of education required because patients may come in through emergency department. Again, setting up for CAR T is a lot of education for places potentially that the patient may come into. Our nurse practitioners are also heavily involved. What I can say in our own experience, and we're getting ready to sort of put a publication together, is that almost half the patients actually we could not keep as outpatients. They were ultimately admitted on the day of infusion. The length of stay for those patients was 16 days, but the other half of patients were kept as an outpatient, and their length of stay was about half. They were sometimes admitted for fevers. Here's a quick case, diffuse large B-cell lymphoma in a 57-year-old female. She received R-CHOP ×6, but went into remission and relapse. She had 3 GDP, an autograft, and to CR. And shortly after her autograft neck node, PET positive, rebiopsy, and CD19 positive. They were referred for CAR T. She was asymptomatic, so we did not use bridging. Her ECOG was completely 0, LDH perfect, just a low burden disease in a highly functional, healthy patient. She received 3.5 × 10⁸, which in my mind is a good dose of CAR T cells. And the total time was 56 days from the first time I saw her to the time she got her cells. She did very well. She remained an outpatient the whole time. Day 30, she had a DS of 2. She dropped her IgG, as they often do when you see the CAR T effect, and she really had no CRS or ICANS. We have other patients that were never admitted, shown here. Again, low LDH. And also, interestingly, these patients who are picked for outpatient because they have good features, also, as you might imagine, do very well with complete metabolic responses at day 30. So the key takeaways, certainly about outpatient, is you need to set up a lot of education around the points of entry, but the reality is 50 to 60% of your outpatients will be admitted. In terms of getting back to improving the CR and PFS, it is a blend of issues that we describe here. I think you need to the team needs to think about all of these, put them together in a blended way, and the efficacy and PFS will follow. With that, I'd like to close and thank all the team in Canada, and also thank your organization for a wonderful conference. And it is a real privilege for me to be here. Thank you.
Thank you so much, Aaron. That was excellent. So we'll open up the Q&A session, and please feel free to write your questions in the chat box. Dr. Mohsen.
Okay, so please, as Dr. Barif mentioned, if you have any question, post it in the chat box, and we will ask the question to the speakers. I will start with a question to Dr. Goodman. Dr. Goodman, is there any place now of etoposide in treating peripheral T-cell lymphoma after the recent evidence of using Brentuxumab plus chip? Do we have Dr. Goodman?
I think he's with us, but he is on mute.
Okay, so we'll try to ask other questions. We have a few questions posted for Dr. Bashagalibo. Dr. Bashagalibo, there is a question saying how you manage DSA in MUD and Haplo settings. Maybe he mean here mismatched MUD and Haplo settings. And in your center, what's your protocol?
How many, can you hear me?
Yes, we hear you.
Can you hear me? So the question is how many haplos and how many MUDs we do? Approximately 50 and 50%.
No, sorry, the question. Prof, the question how you manage DSA and Haplo and the mismatched MUD.
As I told you, we do not select donors on the basis of DSA because we mostly use calculating conditioning regimen. So neither in unrelated nor in Haplo, we select for DSA negative patients. And I've shown you that also by doing this, our rate of graft failure is extremely low.
Okay.
I have a question, Mohsen, for Dr. Foley, if that's okay.
Yes, please.
In terms of improving the outcomes of CAR T cells, what's the role of collecting T cells from the get-go from patients who we know that are high risk for relapse or diffuse large B-cell lymphoma who have like high IPI and high risk for primary refractoriness? Is there a way that we can collect their T cells from the beginning before the lymphodepleting agents?
Yes, no, that's a brilliant idea. I think that would solve a lot of the issues because the cells would potentially be ready. We haven't really been set up for that in the commercial world, and but I think it's a terrific idea. And as you know, there was presentations at ASH looking at diffuse large B2L. And there were some difficulties with some of the trials, but that certainly seemed to be efficacious for some of them.
Okay. So do you have Dr. Goodman with us? He's muted, but we'll ask a question to Prof. Bashagalibo regarding the use of Eltrombopag. Do you have a definition of for failure of Eltrombopag when you start patient and you maximize the dose? At what time you say this patient failed Eltrombopag? Because sometimes we keep giving Eltrombopag and it is sometimes difficult to say that the patient is responding for transfusions or for Eltrombopag. So do you have a definition for failure of Eltrombopag in poor graft function? Professor Bashagalibo? Didn't hear him. Okay, so I think we have a problem with his connection. Dr. Ranon, I have a question for you. What's your opinion about the use of CAR T? Yes, Dr. Bashagalibo?
Sorry, the connection. So the answer is, that's a very good question. And that's why I finished my presentation with the idea of having a randomized trial, because of course you say you're giving the Thrombopod for 1 month, 2 months, and you see nothing happens. So how long should you continue before you stop? I showed you the median time to response is approximately 100 days. So at least 100 days. After 100 days of a Thrombopod, I think you could have a correct doubt that it does work or not. But we will need a randomized trial.
Okay, thank you. Yeah, Dr. Ronan, I have a question for you. What's your opinion about the use of CAR-T in patients with CNS disease?
Oh, that's a very good question. So I think it can work. I know with the Lyso product, the BMS product, they did allow active CNS disease. So I think there's efficacy potentially there. For funding purposes, we have to exclude any active CNS disease in Ontario. So we're, as a single payer, we're kind of we have to abide by the criteria for eligibility. But a person certainly could have had previous CNS disease that's now been treated and essentially resolved. But I think the question is a very good one, and I think it's potentially efficacious. The problem with the Lyso trial was there was only just a few patients, so the numbers are very small.
Okay, thank you. Dr. Goodman, we have a question for you. Is there any place for etoposide in the treatment of peripheral T-cell lymphoma with the current evidence about Brentuxumab Vidotin plus chip?
Yes, that's a great question. So I've never been a huge fan of etoposide and T-cell lymphoma up front. So there's no randomized data that etoposide plus CHOP, so CHOP with 3 days of etoposide is beneficial. There is phase 2 data from the Germans, and there's also retrospective data that the addition of etoposide in those under the age of 60 who also had a normal LDH, that it prolongs PFS. So that's a lot of ifs in that statement. So I will use etoposide in one scenario. Sometimes patients with T-cell lymphoma present with concurrent HLH. And in those patients, like with hepatosplenics or with aggressive HLH symptoms, I'll add etoposide. But outside of that, I'm no longer using etoposide.
Okay, thank you.
I have a question for the
Go ahead.
what's your take on Polarix study with the Brentuxumab first line in DLBCL? Would that change your management at this point for first line DLBCL?
Was that for me?
Yes, that's a good.
Yeah, this is a tough one. It was I don't have much criticism of the study. I think it was a good study. Although they did include early stage, like 10%. I don't know why the hell they did that, but it was a good study. And it beat our CHOP for the first time ever, or in a long time. But the benefit is very modest. It's about 5 to 7% PFS. And it's very expensive. So, I don't treat a lot of upfront as a transplanter, but I can see myself having the discussion with the patient and them still wanting it. And I don't think it's unreasonable to do it. I'm hopeful for a few more years of follow-up, or another year. We'll see that those PFS curves hold and I'll feel better about it. But unfortunately, I have no control over pricing. I think the benefit's modest and it should be priced as a modest benefit, but it's going to cost 30 grand a month or whatever it is. So, but yes, I will discuss it with patients. Are you going to use it?
I would probably do the same approach. Like we just faced one case, we're discussing the same thing, but really tough for deciding. And with the option of CAR T cells, should we keep the money for CAR T cells later on down the road, or invest at the beginning? So it's a tough. I think just raised a lot of questions and discussions.
Yeah, it's going to get more expensive. It's going to, DLBCL used to be a cheap disease to treat.
you know, the bispecifics like mosunetuzumab, they're running those studies too, and things might start getting very, very expensive in that space.
Thank you.
Question to Dr. Bashagalibo. Is there any role for rituximab if there is poor graft function in the setting of ABO mismatch?
Is there any role for rituximab, you said?
Yeah. In patients with poor graft function.
There is no, I don't have any experience with rituximab. There is a trial ongoing with Imapalumab, which is an anti-interferon antibody in the setting of poor graft function, with the idea that interferon, an inflammatory cytokine, is causing poor graft function. That trial is ongoing.
Another question, Dr. Bashagalibo, is there any variation in primary graft failure from center to center?
I'm sorry, what?
Is there any variations in primary graft failure from center to center? So does the center experience or academic center?
I think the, showing you on the slide, the incidence is rather sort of homogeneous between 5 and 10%. What I found incredible is that in the publications I have shown you, the survival is close to 0. So I really don't know why the outcome is so terrible. But as I showed you, if you act very fast before the patient gets an infection, and you do a second transplant, your chances of rescuing the patient is significant.
Okay, so thank you. Sorry, there was a problem with the connection, but thank you. Dr. Ronan, another question. What is your choice of treatment of first relapse disease, DLBCL, with the first relapse, auto versus or CAR-T?
Yeah, it's a very good question. You know, right now, based on the LY12 data, Canadian study run by Dr. Crump, you know, I think if they're eligible for an auto, that's the path we would take right now. But certainly, as I said, the ZUMA-7 and the Transform studies have kind of raised the question as to, you know, whether for some patients, certainly patients who are relapsing within 12 months or who are primary refractory, the CAR-T approach in 2L may be a better choice. But as it stands right now, we're still looking for auto. And of course, as you know, a patient may be ineligible for auto, but they may be eligible for CAR-T.
Okay, thank you. Dr. Goodman, a question regarding your case presented, the 70-year-old with DLBCL, 2 years post-relapsed after treatment. Why he was not eligible for CAR-T?
Yeah, so I take care of, for those who don't know, California, there's what we call the Inland Empire. And for that particular case, it was more social reasons that we could not, there was financial and social reasons to live by the transplant center, and they weren't willing to move for a few months, which we encounter, which is a problem with, you know, auto and now CAR-T therapy. The access to in some of our areas is very limited, and we ask quite a bit of our patients if they want to receive such therapy. That patient's still doing fine, being treated by their local physician on that drug, so it ended up being an okay decision. I do transplants for auto for DLBCL. You know, up to 75 is kind of pushing it for DLBCL.
Thank you. One last question for you, Dr. Goodman. Regarding what is your indication for transplant in peripheral T-cell lymphoma? When do you refer patients for transplant?
Yeah, so that's changed for me. I will say, so I'm a transplanter, so my colleagues are going to be angry at me. But I used to perform transplant for all peripheral T-cell lymphoma in CR1, you know, outside of ALK+. So the ALK positives, that's a no-brainer. We don't need to transplant those patients in CR1. But for ALK negative, or PTCL, NOS, angioimmunoblastics, I used to recommend auto transplant and CR1. I no longer do that. You know, there's just so much data that's back and forth in that space. And the way I look at it is if there's truly some benefit, which I don't think there is, it's probably really, really, really small. And it's quite an aggressive therapy to offer someone without really firm data. Now, for relapsed peripheral T-cell lymphoma, that's a different story. I try to get, if they're eligible, all those patients to allogeneic transplant. I do feel that's the only way that there'll be long-term remissions or perhaps cures outside of special scenarios. So, I'm not doing much auto anymore for T-cell lymphoma. Now, for enteropathy associated and hepatosplenics, those are case-by-case basis.
Okay, thank you. I think we reached the end of the time of the session. Dr. Barifa, can you close the session?
Thank you so much. It has been a pleasure and an excellent talks that we talked Dr. Goodman, Dr. Foley, and Dr. Absugabo. And thank you for joining us. And we'll see you in the next meeting, inshallah. There will be, I think, a small break, and then we'll start the session, the second session. Thank you.
Yes, thank you. Thank you.
السلام عليكم دكتور أحمد حريجي. Yes, Dr. Hreji. Perfect. So, Dr. Hreji will start and will give your idea. Please present Dr. Korea. Just I will introduce you and then you can present right away, Dr. Korea, okay?
Sure, we're live. We're live, okay?
Okay, so are we live?
We're live? We're live.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. I'm glad that me and my colleague, Dr. Ahmed Al-Hreji from Kuwait, will share this very important session about hematopoietic stem cell transplant innovation. This is the second part of today's activity of the annual Saudi Hematology Congress. We will have 3 talks and all very good and important talks. First will be presented by my colleague, Dr. Ahmed Al-Hreji, who is a consultant in Kuwait, from Kuwait. He did his training in MD Anderson, and before that, he was our colleague in King Faisal Specialist Hospital. Dr. Al-Hreji, please go ahead.
Thank you, Dr. Moore, and thanks for the organizing committee for such excellent meeting. Very impressive, actually. This year, every year it's get bigger and better. Today is you have 3 distinguished speakers. We'll go with the second speaker as the Dr. Michael Bishop has technical issues. So second speaker is Dr. Divya Cora. She is an assistant professor of hematology and oncology at the University of California, San Diego. She did her internal medicine residency at Washington University at Louis. Following that, she did her hematology training at Emory Cancer Center at Atlanta with a focus on bone marrow transplantation. She's now taking care of patients with hematological malignancies from diagnosis, treating them if they need transplant. She will take care of them as well. She published extensively. She published numerous abstract and peer-reviewed articles, and served as one of the editorial board at the Biology and Bone Marrow Transplantation Journal. Without any further delay, please welcome with me Dr. Cora, and who will be speaking to us today about the updates on the chronic Gvhd. The floor is yours, Dr. Cora.
Hello, good evening. My name is Divya Cora. Thank you for inviting me to speak here today. I'm a bone marrow transplant physician at the University of California in San Diego, and this evening I'll be speaking about updates in the management of chronic graft versus host disease. Chronic graft versus host disease is a major cause of late morbidity and mortality after stem cell transplant. It's a syndrome of varying clinical features that resemble autoimmune or other immunologic disorders, and it occurs in over half the patients undergoing stem cell transplant. Now, I want to apologize in advance for the next few slides. I have some photos to share. I wanted to show what patients go through when they develop chronic graft versus host disease after transplant, so you can see the problem. These are a few photos of patients with oral and ocular chronic graft versus host disease. In its mildest form, chronic Gvhd of the mouth simply is an irritation. Patients have dry mouth. In its more severe form, patients can have ulcerations that actually limit oral intake due to severe pain. With ocular chronic Gvhd, similarly, in its mildest form, patients may have dry eyes where they require drops multiple times a day. But in its more severe form, it can lead to pain and ultimately even loss of vision. Similarly, the skin can be involved, and in the mildest form, the skin can just have rashes or skin lesions that are a bother, but not a problem. In its more severe forms, skin can become fibrotic, ulcerated. It can eventually lead to contractures and limited range of motion. However, chronic Gvhd can actually involve any organ, genitalia, GI tract, the liver, lung, musculoskeletal system, the bone marrow, immune system, as well as the nervous system. And this can make it very hard to diagnose and ultimately as well as to treat. As you can see from those pictures and discussion, chronic graft versus host disease greatly impacts quality of life after stem cell transplant. The treatment of chronic GvHD itself can lead to numerous complications such as avascular necrosis, osteoporosis, infection, hyperglycemia, insomnia, and we definitely have room for improvement in the treatment and prevention of chronic GvHD. To start with, I'd like to talk about topical therapies that are used. In patients with mild or localized chronic GvHD, we can use topical or local therapies. This table gives a few examples. So for skin, you can use topical steroid creams, you can use calcineurin inhibitor creams. For the mouth, you can use steroid rinses or mouthwashes. You can use calcineurin inhibitor rinses, and the same for eyes, and so on and so forth. Now, while these topical therapies really have not changed in a while, last year there was a publication of using a really safe intervention, 1% progesterone gel on the forehead for ocular chronic GvHD. Patients on this trial were randomized 2-to-1 between the progesterone arm and placebo arm. The gel was applied to their forehead twice a day. All patients were enrolled within 3 weeks of each other to prevent seasonal variation in symptoms. Patients had to have moderate to severe ocular discomfort, and they had to be on a stable immunosuppression regimen. Changes in patient-reported ocular symptom scores, as well as physician-recorded cornea fluorescein staining scores, were analyzed after 10 weeks of therapy. And they saw a significant reduction in both of those in the patients on the progesterone arm versus the placebo arm. So a relatively safe, very well-tolerated intervention that seems that it can make a difference in our patients with ocular chronic GvHD. Now, this is where we'll spend the bulk of our time today, systemic therapy for chronic GvHD. Moderate to severe chronic GvHD requires systemic therapy. The frontline systemic therapy is steroids. Patients are started on either 0.5 milligram per kilogram per day of prednisone or its equivalent to 1 milligram per kilogram per day. This usually requires a very protracted course, on average of 2 to 3 years, and at 7 years, 10 to 15% of patients are still on treatment. The frontline therapy has not changed in many years. There is currently a trial ongoing to evaluate the addition of itacitinib, which is an oral JAK1 inhibitor, up front in chronic GvHD. So this is the Gravitas 309 trial. We're on the second part at this point, and they're looking at steroids in combination with itacitinib versus placebo, and the overall response rate will be analyzed at the 6 months. So more to come on this trial, and we'll see if we actually have any changes in frontline management that arise from this. Now, to move on to a major problem in chronic GvHD, which is steroid refractory GvHD, so second-line therapy and beyond. Steroid refractory chronic GvHD is defined as progression of symptoms while on prednisone at greater than 1 milligram per kilogram per day for 1 to 2 weeks, or stable disease at greater than 0.5 milligram per kilogram per day of prednisone for 1 to 2 months. Despite first-line therapy with steroids, as well as a second agent, often including a calcineurin inhibitor, greater than 70% of patients require subsequent lines of therapy due to the lack of efficacy, but also due to the toxicity of the therapy itself. Until recently, there was no standard of care for second-line therapy. So while I mentioned that in the frontline, things hadn't really changed, in this space, I feel that things have really improved in the last few years. 5 years ago, with this trial, ibrutinib became the first FDA-approved agent for steroid refractory chronic GvHD. This was a phase 1-2 study in 42 patients with steroid refractory or steroid-dependent chronic graft versus host disease. They used ibrutinib at 420 milligrams per day. The median follow-up was just over 2 years. The overall response rate was impressive at 69%, but what I find even more impressive is there was a 31% complete response rate. Of those patients, 60% showed a response in sclerotic manifestations, which, as you know, are very hard to treat. There were frequent adverse events, including pneumonia, fatigue, and diarrhea, which ultimately led to discontinuation of therapy in 43% of the patients. However, in those patients that had to stop ibrutinib, a flare of GvHD symptoms was not seen, implying we don't need to taper and we can just stop in those patients. The next exciting development in the steroid refractory space came with the REACH3 trial. So this was the first phase 3 trial successful in patients with steroid refractory chronic GvHD. Patients were randomized to either receive ruxolitinib, ultimately at a dose of 10 milligrams twice a day, or best available therapy. Now, best available therapy included a myriad of options: ECP, low-dose methotrexate, sirolimus, imatinib, ibrutinib, amongst others. And overall response rate was assessed at 24 weeks. As you can see, the overall response rate was doubled in the ruxolitinib arm as compared to the best available therapy arm. With all the progress in the last few years, in 2020, the NCCN actually published guidelines for stem cell transplantation for the first time. Between 2020 and 2021, there was one important update. In these suggested regimens for chronic graft versus host disease, ruxolitinib is now a category 1 recommendation, which in my mind makes it the new standard of care for steroid refractory chronic GvHD. Continuing on with drug approvals, last year belumosudil was approved based on the ROCKSTAR study. Belumosudil is an oral ROCK2 inhibitor which reduces type 17 and follicular T helper cells and enhances regulatory T cells. In this study, patients were 12 years or older and had active chronic graft versus host disease. They had received 2 to 5 prior lines of therapy for chronic GvHD. In this trial, dosing was evaluated. Half the patients received belumosudil at 200 milligrams daily versus belumosudil at 200 milligrams twice daily. The overall response rate was evaluated. In this trial, a third of patients had received ibrutinib and almost a third of patients had already received ruxolitinib. So as you can see, it was a very heavily pretreated population, and yet the response rates were very impressive. In the once daily dosing, you saw an overall response rate of 74%. In the twice daily dosing, you saw an overall response rate of 77%. To me, what's also impressive is the organ-specific responses. So as you can see, in the joints and fascia, the response rate was 71%, including 20% complete responses. So we know that patients that have joint and fascia involvement and have failed many lines of therapy can be very hard to reverse the manifestations they already have. So this is impressive and I think would translate to an improvement in quality of life for these patients. To summarize the approved drugs now in the steroid refractory chronic GvHD space, we started with ibrutinib, approved after failure of 1 or more prior lines of systemic therapy at 420 milligrams daily, with a 69% overall response rate and impressively a 31% complete response rate. Ruxolitinib was approved after failure of 1 or 2 lines of systemic therapy at 10 milligrams twice a day based on a phase 3 randomized controlled trial, with a response rate of 50% at 24 weeks. And belumosudil is approved after failure of 2 prior lines of systemic therapy at 200 milligrams daily, although in patients on CYP3 inhibitors or PPIs, they need the dosing to be 200 milligrams twice daily. And the overall response rate was 76%. So moving on to second-line therapy that is not yet approved but being evaluated. I want to start with the phase 1 clinical trial evaluating abatacept in steroid refractory chronic GVHD. A little background on abatacept. It is a co-stimulation blockade agent, and its binding of CD80-86 prevents interaction with CD28 and ultimately inhibits T cell activation. In this trial, abatacept was initially given at the dose of 3 milligrams per kilogram, and eventually the dose was escalated to 10 milligrams per kilogram for future patients. It was given every 2 weeks for the first 3 doses and then monthly till 6 months. Patients that were responding had the option to continue with the monthly dosing. 60 patients were evaluable, 44% achieved a partial response, and in those that responded, there was a 50% reduction in prednisone usage. This led to a phase 2 trial of abatacept by the same group, 39 patients, all of whom had moderate or severe steroid refractory chronic GVHD. Abatacept was administered at the phase 1 schedule at the 10 milligram per kilogram dosing. The overall response rate was 49%, all of which were partial responses. The organs with the greatest improvement did include the lung. And I think this is interesting and impressive because lung involvement is also one that is very hard to reverse and improve symptoms from once it happens. There was yet another trial looking at abatacept. This one was 15 patients, same dosing, same schedule. They reported an overall response rate of 40%. One patient actually achieved a complete response. And also here, they noticed a lung response of 89%. I think this implies a lot of promise for abatacept in the chronic GVHD space in patients that are refractory to steroids or initial therapy. So while there have been advances in the treatment of chronic GVHD, treatment still lasts for years in patients and is associated with toxicity. So prevention of chronic GVHD itself is definitely an attractive strategy. The next couple of trials I'm going to discuss are graft manipulation trials. So to start with, ORCA-T. ORCA-T is an industry manufactured engineered T cell graft. In preclinical models, we've seen that infusing regulatory T cells prior to conventional T cells can prevent GVHD, but maintain graft versus leukemia effect without the need of additional agents. In the ORCA-T trials, they looked at 51 patients with high-risk heme malignancies undergoing myeloablative conditioning, enrolled on 2 different trials, a single-center phase 1/2 trial and a multi-center phase 1b trial. The results I'll be speaking about reflect 34 patients who received ORCA-T after dose escalation. And I'll be also speaking of another subgroup of 24 patients who were randomized to test whether all GVHD prophylaxis could be removed. So for patients receiving ORCA-T on trial, they received myeloablative conditioning from day -10 to day -2. They received an infusion of stem cells and regulatory T cells on day 0. No immunosuppression yet. Day +2, conventional T cells were infused, and day +3, single agent tacrolimus was started, except for in the subgroup that was being looked at without any prophylaxis. So ORCA-T showed reduced acute and chronic GVHD and improved GVHD and relapse-free survival. In patients that received it with single-agent tacrolimus prophylaxis, the grade 2 to 4 acute GVHD was 0% as opposed to 33% in the standard of care cohort. The severe chronic GVHD was 4% versus 44% in the standard of care cohort. To backtrack a little, the standard of care cohort was a contemporaneous cohort at a single institution of about 140 patients undergoing the same type of transplant. In patients that were randomized to the prophylaxis versus no prophylaxis arm, grade 2 to 4 acute GVHD was 0% in the single prophylaxis arm and 58% in the no prophylaxis arm. All of the GVHD in the no prophylaxis arm responded to steroids with no GVHD-related deaths. So impressive results with ORCA-T. To move on to another graft manipulation strategy, involving T cell depletion. So we know from the past that complete T cell depletion of a graft reduces GvHD, but it delays immune reconstitution, increases opportunistic infections, and may reduce survival. And it's been previously demonstrated that naive T cells cause severe GvHD in murine models, whereas memory T cells cause milder or no GvHD and retained graft versus tumor activity. This is a strategy that selectively depletes naive T cells using immunomagnetic beads targeting CD45RA expressed on all naive T cells, but absent on most memory T cells. This strategy was used in 3 different phase 2 trials. These 3 trials all included patients getting myeloablative conditioning. The donor sources were different between the 3, and the GvHD prophylaxis regimens were different between the 3. But in all, patients after conditioning received HLA-matched CD4-selected peripheral blood stem cells, immediately followed by CD45RA depleted cells from the CD34 negative fraction. So the chronic GvHD, the cumulative incidence at 3 years of mild chronic GvHD was 6%, of moderate was 1%, and severe was 0%, which led to an impressive chronic GvHD-free, relapse-free survival rate of 68% at 3 years. So these were a couple of graft manipulation strategies that definitely show promise. And while they're impressive, they're not readily available to all sites at this point in time. So I think there is something to be said about using drugs easily available or products easily available. So to circle back to abatacept, in December of 2021, abatacept was granted FDA approval in combination with methotrexate and calcineurin inhibitor for GvHD prophylaxis in 7 out of 8 or 8 out of 8 matched unrelated donor stem cell transplants based on the phase 2 abatacept trial. In the phase 2 trial, abatacept was given on day -1, +5, +14, and +28, along with methotrexate and a calcineurin inhibitor. While there was a reduction in acute GvHD in both arms, and in fact, an overall survival benefit in the 7 out of 8 arm, there was no difference in chronic GvHD. Now, for a variety of reasons, there's a lot of interest in calcineurin inhibitor-free regimens for GvHD prophylaxis. And at UCSD, Dr. Dimitri Zakanis and I are evaluating abatacept in combination with post-transplant cyclophosphamide as a novel calcineurin inhibitor-free regimen. So our primary objective in this trial is to see if this novel combination of post-transplant cyclophosphamide and abatacept can induce tolerance, i.e. reduce the risk of chronic GvHD by 1 year as compared to the standard of care with methotrexate and tacrolimus. So this is a randomized phase 2 trial. In the standard of care arm, patients receive myeloablative or reduced intensity conditioning, and this is followed with GvHD prophylaxis with methotrexate and tacrolimus. In the study arm, patients receive the same conditioning, but their GvHD prophylaxis is cyclophosphamide given at day +3 and +4, and followed by abatacept given day +5, 14, 28, and then monthly until 6 months post-transplant. And patients are followed for a year. At the time of this talk, we had looked at 27 patients that had been enrolled. 12 patients were on our study arm, all of whom engrafted. Median time to neutral engraftment was 15 days. There were 3 deaths due to relapse. There were no transplant-related deaths. There was no cases of chronic GvHD, no cases of grade 3 to 4 acute GvHD. There were 4 cases of grade 1 acute GvHD and 1 case of grade 2 acute GvHD, all of the skin and all very responsive to topical therapies, and no other significant safety signals. The follow-up has been almost to 2 years in those patients. The standard of care arm so far had 15 patients with 3 deaths as well, 1 death due to relapse, 1 related to transplant, 1 death after graft failure. 3 patients had grade 3 to 4 acute graft versus host disease requiring systemic therapy, and 6 patients had grade 1 to 2 acute graft versus host disease. There were 5 cases of chronic GvHD. In 3 of those patients, they were already on prolonged immunosuppression for their acute GVHD. So the combination of post-transplant cyclophosphamide followed by abatacept for 6 months is feasible. All the patients so far have been grafted on trial on the study arm. So far, no transplant-related deaths on the study arm, and no grade 3 to 4 acute GVHD and no chronic GVHD on the post-transplant cyclophosphamide and abatacept arm. And relapses appear to be in the expected rate. So hopefully more to come from us there. In conclusion, chronic GVHD remains a major problem following stem cell transplantation. There's been 3 new approvals for steroid refractory chronic GVHD in the last 5 years. I generally start with ruxolitinib in this situation. New studies for prevention are ongoing and show promise. And with that, I'll stop. I'll be happy to take any questions during the Q&A, but if you'd like to email, my email is there on the slide. And thank you again for having me today.
Matt Al-Hraji, he's here.
Thank you so much, Dr. Cora, for an excellent and elegant talk. Now, our next speaker is Dr. Riyad Al-Faqih. Dr. Riyad Al-Faqih is an associate professor at Al Faisal University, and he's the head of the clinical research at the King Faisal Specialist Hospital Research Center in Riyadh. Today, Dr. Al-Faqih, he will speak to us about the CAR T-cell programs at King Faisal Hospital. We apologize for not having Dr. Michael Bishop today due to connection issues. So we'll have Dr. Riyad Al-Faqih going next. Please welcome with me, Dr. Riyad.
Assalamu alaikum. Can you hear me?
Yes, we can.
Okay, let me just share my screen. You can see my slides.
Yes, we can, Doctor.
Okay. Well, thank you much for having me, and thanks for the organizers. So I'll talk quickly about the King Faisal experience with CAR T-cell. As you know, we established our program a year ago in late 2020. So we've had a year of experience with the CAR T-cell. So here's my agenda. I'll go over an introduction, then talk briefly about the approved CAR T-cell products from FDA. Then I'll go over the King Faisal process and the activities going on. So this is the timeline of the FDA-approved products. It started in August 2017 with the approval of Tisa-cel for pediatric ALL up to the age of 25, all the way to October 2021 with the approval of Brexucel. And actually, you can add one product recently approved a week ago for the treatment of multiple myeloma, and that's the Cilta-cel that was approved on 28 February. So here's a tabular view of the approved product. We have Liso-cel, Brexucel, Tisa-cel, Axi-cel, Ida-cel, and Cilta-cel. A lot of names, as you see, and a lot of indications, but basically it's B-cell malignancies, diffuse large B-cell lymphoma, relapsed refractory, mantle cell, acute lymphoblastic leukemia, multiple myeloma as well. So these are the indications, and follicular lymphoma, as you all know. So these are the indications. I will not go into the details. I'll show you the registration trial for each product very quickly. So here you see the pivotal trials for CD19 CAR T cell and diffuse large B-cell lymphoma. All of them had indication in the relapsed refractory setting. And here you see the ZUMA-1 trial for Axi-cell. And as you see, long-term survivors are around, without progression, are around 35 to 40%. The Juliet, the Tisa-cell, Kymriah, the long-term survival rate is around 30% without progression. And this is the product we have at King Faisal currently. We're working on getting the other products approved as well. And then you have the Liso-cell, and the Liso-cell, the long-term survival without progression is around 35 to 40%. This is the Eliana trial. That's the trial that led to the approval of Tisa-cell in relapsed refractory ALL. And as you see, the event-free survival runs around 50% on the long run. So a little bit better progression-free survival as compared to the diffuse large B-cell lymphoma. And then here we have the ZUMA-3 trial, and in ZUMA-3 trial, you see my slides? Okay. So in ZUMA-3 trial, the median relapse-free survival is 11.6 months. This is a recent trial, and this trial used Axi-cell for or Brexu-cell for patients with relapsed refractory acute lymphoblastic leukemia without age limitation, while Eliana had the age limitation up to the age 25. So here there is no age limitation, and this product is now approved for adult ALL as well. This is the ZUMA-2 trial, and this is Axi-cell for relapsed refractory mantle cell lymphoma. And as you see, the progression-free survival here runs around 55 to 60% on the long run. So very good result for this relapsed refractory population. And as you see, the overall survival on the long run is above 60% as well. These are the two products for multiple myeloma. Here we have the KARMA trial, and as you see, the progression-free survival. So both products are approved for myeloma that failed 4 lines and failed the major drugs in myeloma, IMiD, proteasome inhibitor, and anti-CD38. And as you see here, the PFS is around 25% for this product, while the new product, the PFS, the median PFS is 12.4 months. And here's on the long run, as you see, sustained progression-free survival around 55 to 60% in this very refractory population, specifically in people achieving, stringent CR or VGPR. Stringent CR is the blue curve, and VGPR is the red curve. So basically, if you get the product and you achieve stringent or very good partial remission, your expected PFS runs between 55 and 60% at 2 years. Now, all these products are produced and all of them require apheresis of the blood at the treating center, then sending the cells. In our case, we apherese in Saudi Arabia, and then the cells will be used, and then if they pass the steps, they will be shipped back, and then patient will receive some chemodepleting therapy and will receive the cells. So pretty extensive process and multiple steps where failure can happen. So not an easy process and needs a lot of manpower involvement, especially in the coordination steps to make sure the process is safe. So what do we do at King Faisal, or what we did? In 2021, we infused 14 patients, and I have another slide showing the current infusions. So we infused 14 patients, 8 of them are diffuse large B-cell lymphoma, 6 are acute lymphoblastic leukemia. And here you see the survival of the ALL is 100%, the lymphoma 88% at 1 year. And here you can see a quoted 1-year survival from the reported studies, acute leukemia 77%, lymphoma from 48 to 66%. So we match these. All in all, our overall survival is 92% in this first year. And the rates of CRS at ICANS, as you see here, the ICANS was 0 of the 14 developed ICANS. However, in the recent 3 products, we've had advanced ICANS cases. But during 2021, we had 0 cases. For CRS, we had 12 out of 14, 85% developing CRS, with the median of 2 days until the onset of CRS after infusing the CAR T cell. The grade was on average 2, the median. However, it was between 0 and 4. 11 of the 12 patients required tocilizumab at a median of 2 doses, but the range was 1 to 4. 5 patients with CRS required treatment with dexamethasone in addition to tocilizumab. So here's an updated slide about the activity. This is as of last day of February. We screened 64 patients. As you see the last line here, 64 patients were screened. Some of them, the red and orange, unfortunately died before the product is manufactured. And this tells you about the disease and the aggressiveness of the disease, especially the lymphoma. And sometimes you may enroll the patient in the program apheres, but unfortunately, the patient will pass away before you even produce the product. And sometimes you produce, but you can't infuse. So screened 64, apheres 39 patients, dispatched to the USA 31, manufactured 30 products, returned 28, and from these, 17 are infused. As you see here, the blue bars and the red bar, these are expired patients after receiving the infusion. So our eligibility, we set up our own eligibility as we are just starting the program, so a little bit more stringent than the labeled indication. Performance should be less than 2. For B-cell ALL patients should be less than 25 years because we have the T-cell product. We don't have the others. And of course, the patient should be in second or later relapse with detectable disease. Now, this is subject to change because we're getting more information about the product, especially in the CNS positive patients. And for large B-cell lymphoma, we set up the age from 18 to 75, while the labeled product doesn't have an upper age limit. And the indication is relapsed refractory large B-cell lymphoma after failing 2 or more lines. And the lymphoma has to be diffuse large, not otherwise specified, or diffuse large arising from follicular lymphoma. As you know, the registration trial for the T-cell excluded Burkitt, excluded the patient with primary mediastinal, so we cannot treat these patients with our product. And of course, part of the eligibility is the ability of the patient to survive during the period of production, which is 5 to 8 weeks. So the patient has to have an expected survival of around 2 months at least until the product is produced and comes back. Now, there are multiple contraindications for the treatment, and organ dysfunction is one of these contraindications in the form of renal failure, liver elevated LFTs, cardiac events, recent cardiac events, low ejection fraction, or recent myocardial infarction, or recent intervention. Clinical pericardial effusion is a contraindication. Patient has to have a good pulmonary function test. and active infection should be ruled out before recruiting these patients. Because as you know, we are depleting the B cells with the product, and this can result in uncontrolled infection if these were not controlled before infusion. Now, HIV is an absolute contraindication, same as hepatitis B and hepatitis C. But these are subject to change. But until now, you know, if you have a hepatitis B surface antigen positive, these patients are not eligible for CAR T-cell production. Same if you have hepatitis B core antibody positive without surface antibody positivity. This is a contraindication as well to manufacture the cells. So unfortunately, even if the patient disease is in line with the indication, we cannot manufacture the cells, and as such, we will reject these patients. Autoimmune disease, and this is meant to be active autoimmune disease, needing immunosuppression is an absolute contraindication because these patients are taking lymphodepleting agents as part of the treatment of their autoimmune disease, and this same treatment will paralyze the CAR T cell, and as such, this therapy is contraindicated. Active malignancy, except carcinoma in situ, or if the patient has been disease-free for 3 years at least before considering them for CAR T cell. A patient who had received an allogeneic transplant, and here specifically the ALL patients, should not have active grade 2 to 4 acute GvHD or extensive chronic GvHD requiring treatment, because the same concept as autoimmune disease, you are treating them with lymphodepleting or lymphoparalysing agents, and as such, you will paralyze the CAR T cell. History of stroke, seizure, intracranial bleeding, or memory loss is also a contraindication because, as you know, one of the complications of these cellular therapy is ICANS and neurologic toxicity, and this can be confused if the patient has a baseline or active neurologic problem. Pregnancy is a contraindication. Of course, CD19 negative ALL, because again, these are CD19 directed therapies, and active CNS disease, and this is subject to change as there are now trials in positive or active CNS ALL and lymphoma as well. Now, when the patient is sent to us, we make sure the disease fits the inclusion criteria. Patient doesn't have any exclusion criteria in terms of the age, comorbidities, and performance. And one major thing to do is to make sure the last chemotherapy is washed out, and there are specific washout period for different drugs to be able to manufacture the T cells. As you see here, some drugs require more than 6 months to wash out, like Blantomab or ATG. Bendamustine, fludarabine, more than 12 weeks, and these are frequently used in the treatment of lymphoma, sometimes in ALL, but not frequently. Allogeneic therapy, 12 weeks, and so on. As you see, for each drug, it has a washout period that has to be respected before you lymphophorese the patient and send the cells for production. So we require the referring center to send detailed history with dates, specifically the date of the last treatment and the type of the last treatment. Hepatitis and HIV serology would help to expedite the process. Current and initial CNS status of the patient, last imaging reports and CDs, pathology report and paraffin blocks, and if available, echo report and pulmonary function test, because as you saw, this is time sensitive and requires 5 to 8 weeks of cell processing and production. So if these are available when the patient comes in, this 5 to 8 weeks probably can be shortened to 5 weeks rather than the upper limit of 8 weeks. And as such, the patient can be treated earlier. And this is our website if the patient want to upload their documents ahead of the visit. At King Faisal, all these patients will be discussed on a tumor board, and decision to proceed with treatment or to enroll in the program require a majority of votes from the CAR T-cell therapy physicians. Patients who consent are considered enrolled in the program, and then they're ready to consent for apheresis if they pass the pre-apheresis testing, which we'll see in a minute. And as I said initially, even if the patient has entered the program, doesn't mean the cells will be produced, or even if the cells are produced and back to the country, doesn't mean that the patient will receive the cells, because as you know, this is a dynamic process and the patient's condition can change at any minute. So this is before leukapheresis. This is what we do. This is the workup. It's pretty much like allogeneic transplant, doing serologies, infectious, and organ function assessment. And you want to make sure the absolute lymphocyte count is in good level, ALC more than 0.5, and if less than 0.5, then you check CD3 and should be more than 0.15. Platelets should be in good range for the apheresis procedure. And sometimes, if specifically in ALL, if a lot of blasts are in the peripheral blood, this blast contamination can impact the production. And we've had some patients with production failure because they have a lot of blast. Of course, we review the washouts before leukapheresis for different product, and we aim to collect 1 to 4 TNC, total nucleated cells. Now, sometimes the patient is unstable and the disease is very aggressive, and you'd like to bridge them ahead of the CAR T cell. And here the bridging is preferably done at King Faisal, unless the logistics are better for the patient in his hometown or home country. When we do bridging or when we choose therapy, we avoid therapies that can deplete the target, like Blantomab and CD19. The aim of this treatment is to control the disease, including the CNS disease or CNS prophylaxis, preserve the patient performance because it's one of the eligibility, avoid serious infection, because if you get serious infection with these bridging therapy, the patient becomes ineligible if they have active and uncontrolled infection, and of course, no conception. So once these cells are gone and produced, here's what we get. We get what we call certificate of analysis. And this is like a birth certificate for these cells. As you see here, it's a detailed description about the quality, including appearance, identity of these cells, viability, potency, total counts, number of viable cells. So very extensive quality measures before the cells are shipped back. And the product has to pass all of these. Now, if one of them is not passed and the others are passed, here we can do what we call out of specification infusion. If the specification that is not met is deemed to be safe, but may affect the efficacy, the safety is first here. So these cases are discussed on tumor board and with the company before infused, and the patient will be consented on a specific consent. Now, once the cells are back and the certificate of analysis is okay, we repeat the workup before infusing the cells. And as you see here, extensive workup as well, including serologies, pregnancy tests, hepatitis, HIV, dental work sometimes is required, PET CT or other imaging. We review the certificate of analysis, make sure everything is fine. And if we have out of specs, then the patient has to be consented on a specific consent. And then you can start your conditioning therapy followed by the infusion. So the conditioning therapy is usually flu-cy, and patient will get the infusion. And in the immediate post-infusion period, they will be hospitalized. We will be watching for the acute toxicities in the form of cytokine release syndrome or ICANS. And then, of course, infections, because these patients develop cytopenia, and from the conditioning and from the cells and the cytokine storm, organ-specific toxicities. And of course, after this short period of observation in the hospital, the patient will be outpatient and monitored for long-term complication. So following the infusion, the patient will stay in Riyadh till day 60 around the hospital. They will be on antimicrobial prophylaxis. They will receive IVIG every 4 weeks because, again, you're depleting the B cells, the immunoglobulin producing cells, and they will be watched for CRS and ICANS. As you know, these can happen up to 2 to 3 months after infusion. Extremely rare. to have delayed CRS or ICANS, but these can happen. Now, after day 60, the patient will have scheduled visit for a year at King Faisal, including disease assessment. And after 1 year, the patient can go to the referring center. However, they still have to follow yearly with King Faisal for 15 years as mandated by the Saudi FDA. Now, patients sometimes receive CAR T-cell as a bridge to allogeneic transplant, and it is preferably to have the allogeneic transplant at King Faisal because of the complex logistics here, unless the patient has another reason to have the transplant back home. So, as I said initially, we currently have Tisa-cel or Kymriah available at King Faisal, and it's indicated for pediatric ALL up to the age 25 and diffuse large B-cell lymphoma. Now we have 3 trials opening very soon. An in-house trial for ALL patient, relapsed refractory, up to the age of 60. And this trial is in the last steps of verification with the Saudi FDA. We have 2 myeloma trial, the CARTITUDE-2 study sponsored by Johnson & Johnson. And the trial is fully approved from our institution. Currently, the company is granting Saudi FDA approval, and expectedly soon we will start. And the other trial is the PHE trial, which is the Novartis anti-BCMA CAR T-cell, also approved by King Faisal IRB and awaiting full Saudi FDA approval. We have 2 trials using the closed system in-house production, like the first trial, one for pediatric ALL, one for diffuse large B-cell lymphoma. These are not submitted to Saudi FDA yet, but these are coming along. So this process is very complex and delicate, so please call early. Any patient with ALL, diffuse large B-cell lymphoma, when they relapse or they have refractory disease, please call. We can optimize the process and agree on, a salvage regimen that doesn't impact the collection of the cells, or maybe collect the cells before the salvage regimen. As you know, the patient condition change every day. This is a dynamic process, so close communication with the treatment center is very important to ensure safe and successful outcome. I recommend for everybody to follow this Twitter account. This is the King Faisal program, run by the King Faisal program. We also have a CAR T-cell guide for referring physicians, and I'm happy to share by email, by WhatsApp. Please contact us and we'll share it with you. And with that, I will finish and thank you all.
Thank you, Dr. Riyad Al-Faqih, as usual. Excellent presentation, and I enjoy your speech all the time. Dr. Ahreji with us, nice, yes, and we will proceed because Dr. Bishop was not able to join, so we will proceed now with the question and answer. Dr. Ahreji, if you allow me, can I ask Dr. Cora about the chronic GVHD? This is my interest, the GVHD. Our center was part actually of REACH 3 study, so we involved with the ruxolitinib. The question, what do you think of the combination of ruxolitinib and ACP in those patients with lung GVHD? And the question, how for what, like if you will start ACP, you will continue as a maintenance for how long?
That's a great question. I use it fairly commonly in combination for a lot of these patients. I feel like we need more and more treatment options. And are you saying how long will I continue the ruxolitinib versus or the ECP?
Yeah, so both actually. So first the ruxolitinib, and then maybe
it honestly depends on the patient's Availability. As you know, the ECP can be so hard for people to get to. So if the patient lives far, I tend to wean the ECP first just to make it a little bit easier on them. I have patients that like drive 2 hours every, 2 to 4 weeks to try to get here for ECP. On the other hand, I have a fair number of patients that have either invasive fungal infections, and I'm really trying hard to minimize their immunosuppression, and then I'll wean their ruxolitinib first over, the first, after they've seen response, after the first 6 months, try to decrease the dose by half, and then a month later or 2 months later again by half to get them off altogether, and then work on the ECP.
So in our patient with the lung GVHD, they not tolerate steroid. That's why we need to keep something. Usually we try to keep ECP every month or every 2 months. Not sure if you sometimes do this, if they are like living around your center.
Yes, I continue that. I have a guy with lung GVHD who's been on ECP now 6 years. He is now 80 years old, but we're still going on. And we've tried to extend him to every 6 weeks, and it doesn't work out. He keeps having flares, so we just go right back to every 4 weeks. Yep.
4 weeks. Tough, and yeah, the cost is an issue also. Anyone want to ask Dr. Cora? Any question? So I have another question about the ruxolitinib dose. Did you try to increase if patient is not responding? Like I know with REACH 2, REACH 3, we were capping on 10 milligram BID, but any in your practice, did you increase the dose in some patients?
Yeah. I have not, and especially now that we have belumosudil available and some of these other options, I tend not to actually try increasing and just start looking at trying to be able to get approval for belumosudil from our patients' insurances.
Perfect. Thank you.
Thank you, Dr. Cora. Just a question regarding the ibrutinib. How do you see its tolerance in comparison to the ibrutinib used in other indications?
Yeah, a lot of my patients do have trouble tolerating ibrutinib for their chronic GVHD. Some of the same patient we were discussing, my lung patient, I had him on ibrutinib, but he has numerous squamous cells, and the problem ends up being, of course, the bleed risk. But for tolerance, I think it's harder for our patients with chronic GVHD than sort of my patients with mantle cell or CLL that are on ibrutinib. I don't know if that's just because they're so frail from their transplant and GVHD process to begin with, but I do think it's an excellent drug in the setting, just hard to tolerate. The responses again are so encouraging, and the complete responses based on the smaller trial.
For a few patients actually didn't work with the chronic GVHD of skin. I didn't have marvelous improvement or stabilization at least. So, but only a couple of patients we tried the ibrutinib. If you allow, also I have a question about patient who was having chronic GVHD. All the organs improved except the eye. Actually, they try even the plug of the ducts and of the bilaterally, and now patient is off immunosuppression and only on topical. Did you face eye GVHD? Do you have any new approach by your ophthalmology, like a special lens or albumin, or what you are using?
Yeah, so they have so many new lenses now that I have a hard time keeping up, but I do send them there. I often have the patients use the autologous serum eye drops, and I have a 50-50 response to that. Some of my patients, the day they start it, they're like, oh, it's amazing. And others, they pay the money to get them made for them, and they have no response. But I think for those that respond, the response is so quick for the autologous serum eye drops, and it's so non-invasive. The lenses I like. They seem to help with the ocular pain a fair amount and the dryness. Beyond the lenses and the drops, I don't know that our ophthalmologists, at least here at UCSD, are doing more than that in the chronic GVHD space.
Yeah, unfortunately, it's not available in our center as well.
So I think one of the also challenges we have patients with oral GVHD, and we need to spare them from the systemic steroid. What's the best combination you're using?
For the oral, if it's severe, I've had a couple of patients, and we don't offer this at our center either, but they have gone either out of the country or to other centers that have gotten laser therapy for their ulcerations, and that's helped dramatically. I have a patient who, the oral was what kept flaring as they kept tapering, and he finally got the laser therapy, and we've been very successful in getting him off therapy. It's just tough because we don't even offer it here, so it's hard to find a place to send them. That's been sort of the best. I use a lot of Kenalog and steroid paste, steroid rinses, of course. I've tried Tacro rinses to get away from systemic therapy, but I think at the end of the day, what I found most successful was the laser in several patients that had it done at other places.
Very interesting. Yeah. We not have it. One question now in your table with the topical, which we should really push for more topical in those patients. You put lung GVHD and you put the topical steroid. I guess you mean budesonide, yeah? The budesonide mechanism of action, it's mainly to improve the other medication absorption. This is, I think, the idea.
Local anti-inflammatory effects as well. Here, honestly, our pulmonologists have us do the fluticasone more often than the inhaled budesonide, but I think in general, just the local inflammation. I still am the abatacept data for lung, even though it's tiny, that has fascinated me. I have actually tried that, and I will say in my small experience, while it's been really good for some of the other chronic GVHD manifestations, I've not had the best response in the lung patients that I have. I think in some of these lung patients, it's just been too long, and probably anything I try at this point might not actually help, but it's just so limiting in their quality of life that you keep trying anyway.
We had a couple or maybe more of patients who underwent a lung transplant after a chronic lung GVHD. I think we did maybe 4 or 3 or 5 patients.
I have 3 of mine, actually, all doing good.
Oh, can I ask? I have not actually had one yet that's successfully undergone, mainly because of all their other manifestations that they're too ill.
The most recent one was on 19th February, actually. Patient who has been on the ventilator for 8 months, ventilator dependent, and then got transplanted, 20 years old, ALL, chronic GVHD. So hopefully she'll make it. She's doing well.
Inshallah. Thank you, Dr. Cora. Thank you very much. It was a very nice presentation. We will give question now to Dr. Faqih. Please go ahead, Dr. Hreji.
Yeah, first of all, I'd like to thank Dr. Faqih for the excellent talk. And I'd like to thank the whole group at King Faisal for bringing this innovation to the region. And they're the first center to start the CAR T-cell program. And it brings a lot of hope to our patients, to the physicians working in the region. And he made it very clearly how to refer, when to refer, and all the information required. The question is, what is the waiting time now in your practice for patients to get enrolled, accepted, and then they got the cells?
I would say very quick. We don't have a waiting time. We try to accommodate everybody because, of the expected 5 to 8 weeks to produce the cells. So as soon as we get contacted, we get to see the patient immediately, within 1 week, actually. But again, communication is essential. So a phone call, you all have our contact and email, then we can start the process, because you'd like to minimize any delay that you can during the process because of this.
Myeloma.
Oh, myeloma, we still don't have a product available. The FDA approved product are not available in the country. We do have the 2 trials, and expectedly late April, early May, they will open the 2 trials, the Cartitude and the Novartis BCMA. So hopefully May will be up and running.
There's one question from Dr. Manar Khalil to Dr. Cora, do you adjust the ruxolitinib with the posaconazole use?
Ruxolitinib with posaconazole, yes. Or often, if they're still on high-dose steroids and need it, sometimes I do end up giving something like micafungin.
We don't adjust. In REACH 2, I think, or REACH 3, they didn't include this, but interaction can happen, of course.
Right. And I think, again, as we kind of said, I don't escalate over 10. Probably we'd be fine with that dosing and just monitoring for toxicities.
I think we have a final question to Dr. Faqih from Dr. Sayed. Do you follow up the patients who underwent CAR T cells for CAR T persistence, or do you check VCN? If yes, do you use the expression CAR expression T cells?
Unfortunately, no. You know, we rushed to start the clinical program. Novartis is happy to share, you know, the kit on how to detect these cells, the persistence. But again, we rushed into the clinical side and to get the program up and running. Now we're starting to develop these other collateral and scientific tests in collaboration with Dr. Sayed, actually. So he's establishing a core facility for vector production and CAR T cell production. So hopefully we will get to do all these tests in his lab, but not yet, no.
Perfect. So I think we're done for today's session. I want to thank everyone, all our distinguished speakers, Dr. Cora, Dr. Faqih, and my colleague, Dr. Al-Hraiji, for co-share this session. And I want to thank the Saudi Society of Blood for their improve, I mean, our education by organizing this scientific meeting in a very advanced and thorough way. Thank you very much, and have a nice night, everyone. See you hopefully in the future events. Goodbye.
Thank you. Good night.
Dr. Al-Hraiji, please, if you will add, go ahead.
Yeah, thank you so much for everyone. Thanks, Dr. Cora. Thanks, Dr. Faqih, Dr. Marwan, all the audience and organizers as well, and sponsors. I hope to see you face to face soon.
Inshallah.
Bye-bye.
Bye.
Thank you.